start broadcasting and recording. Good afternoon, everybody. Welcome to our live chat session with Dr. Naidu and Dr. Kalra. We are so thankful to have them with us today. I am Andrea Baer, the Executive Director of Mended Hearts, and they are going to be talking to us today about dealing with heart failure as we age. So TAVR, hypertrophic cardiomyopathy, and their intersection as individuals age. As you know, Mended Hearts, and if you don't know, Mended Hearts is a nonprofit organization who provides support, education, and advocacy to cardiovascular patients and their families across the lifespan. We have chapters in 44 states, 40,000 members, and as we are working to reach more people virtually, this was a great idea and something that we were so honored to have the doctors join us for. So without further ado, I am going to turn it over to them. And if you have any questions, everyone is on mute. If you have questions, please type them in your chat box, and we'll be sure to get to the questions at the end of the presentation, and there'll be plenty of time for that question and answer when we're done. Okay, I will turn it over to you all.
All right, great. So thank you, Andrea. My name is Dr. Srihari Naidu. I'm the director of the Cardiac Cath Lab at Westchester Medical Center. Here at this institution, we do a number of procedures for heart patients, and personally, I run a very busy practice in both Long Island and in Westchester. My focus has been on procedures to help patients with heart disease, from stents to valve procedures to fixing holes in the heart, and then a unique procedure called alcohol septal ablation for this one disease called hypertrophic cardiomyopathy. The impetus for this webinar really is that I think it's very important to talk directly to patients. We do this on a day-to-day basis in our practices, but I think patients need to be very informed. And if people don't ask the right questions, they may not get the right solutions. And doctors are very busy. Sometimes you have to seek care outside your institution or your region to get the very best. And we're going to talk about a little bit today is about heart failure, but one particular form that is a valvular problem, but also a muscular problem. And when you have the two of those things together, sometimes you need very specialized treatment. And the reason we started this webinar today is because myself and my colleague, Dr. Kalra, came out with a paper about a month ago that was a publication about these two diseases. And so what we're going to do is take you through what these diseases are, what heart failure is, and some of the questions you might ask your doctor. But first, I want to introduce Dr. Kalra and have him say a few words about where he is, what he does, and then we'll move into what heart failure is. Dr. Kalra?
Well, Andrea and Dr. Naidu, thank you both for having me on this webinar. Thanks for the opportunity. Dr. Naidu and I have gotten to know each other very well over the past 1 year. I consider him a mentor, first up, and also a dear friend and a colleague. I have a high regard for him. I'm an interventional cardiologist at the Cleveland Clinic. I work at one of the regional centers for the clinic at Akron General Medical Center. My focus is on coronary and structural heart interventions. I do both, cases involving, stents as well as prosthetic valves. I've always had an interest in hypertrophic cardiomyopathy since training days, and have been involved in clinical research on that aspect. And, that was the intersection for myself to get to know Dr. Naidu more in person. It was a natural attraction because of his expertise and his interest in the disease. And he actually has a world-class textbook that he edits on the topic. So the attraction was very natural. And, just alluding to the paper that he mentioned, is a topic which is becoming more and more relevant, for patients as well as for us physicians, and that is the intersection of the two disease states, hypertrophic cardiomyopathy and aortic stenosis, and how they interact, particularly with the advent of transcatheter aortic valve replacement, now that aortic valves are being replaced more than ever, and very minimally invasively. I think these conversations are going to become very, very important, and I think like Dr. Naidu said, and an informed patient is all that we ask for, because it challenges us as well, it pushes the envelope, and it's all for a unified goal, and that is the best outcome that you can achieve for your patient.
Okay, great. So I'm going to talk a little bit about what heart failure is. So, so for all of you in the audience, when we think about heart disease, we oftentimes think of heart attacks, things that can hit you pretty hard. A heart attack or a stroke, these things can have lasting consequences, but they happen suddenly, either a loss of a function, such as speech or motor, or chest pain causing some damage to the heart. But really, after you get past those two things, the one thing that has really become an epidemic, really, in some regards in our country is heart failure. If you think about the heart, it has to function in a way that it produces enough blood flow to circulate the blood. So what happens, the heart has to pump, the blood has to get through valves, which are the doors of the heart, it has to get out, and enough of that blood has to get out per minute to provide all the vital functions. There has to be enough blood to your brain, to your liver, enough blood to your kidneys, so that all the functions happen. And also, that blood has to increase when you exert yourself. If you climb stairs, if you want to jog, if you want to do anything, even if you eat, more blood has to circulate around the body to get blood to those areas. Otherwise, you're going to have problems. What are the problems? Well, when you start developing heart failure, which is basically that you can't get enough blood to those organs as the organs want, as much as the organs want, you start feeling symptoms. And we tend to divide heart failure into two forms. One is that things, initially, you don't get enough blood to those organs. So you notice things like fatigue, you get more shorter breath, you get more tired. Some of the organs get some dysfunction. So some people with heart failure have kidney problems where your doctor might say, your creatinine is a little high. You don't know what that means. You don't feel anything, but it means that the kidney is not getting enough blood flow. And that's resulting in some kidney damage over time. As things progress and the heart continues to have trouble moving blood forward, blood will ultimately back up. And where does it back up is the lungs. And so people start getting congestion. And when we talk about congestion or lung congestion or pulmonary congestion, it means that the blood is backing up in the lungs. And if you think about the lungs like a giant sponge, the lungs fill with blood, and naturally they can't inflate as much as they're supposed to, and you feel short of breath. And if there's too much fluid in the lungs, the oxygen goes down because the fluid is taking up the room for where oxygen would come in and get into your blood. And that's called pulmonary edema. So people with heart failure feel short of breath, they feel tired, their legs may feel like pain as they walk because not enough blood to their legs. And over time, they get more and more short of breath to the point that they start retaining fluid, more congestion, they can't lay flat, they have to sit up in bed, they're sitting on, they're laying on 2 or 3, 4 pillows sometimes just to make sure they can breathe better, because sitting up or standing is an easier way for your lungs to breathe than laying flat. And they start getting swelling in the legs. Those are all signs that the heart is not able to push blood around as well. So the kidneys say, well, if I don't have enough blood, maybe I'll make more fluid. So they retain fluid. And the person survives and does okay at the expense of not being able to breathe so well. So that's what heart failure is, but fundamentally it's the blood unable to get out of the heart. So that means you need blood getting into the heart and enough blood getting out of the heart. And any part of the heart can disrupt that. You can have conduction system problems where your heart rate is too low, like bradycardia, and needing a pacemaker. You can have problems where the heart rate is too fast, needing a defibrillator or medications. You can have problems with the lining of the heart, called the pericardium. You can have problems with the muscle of the heart. And you can have problems with the valves of the heart. I'm going to focus on the muscle and the valve because those are the most common causes of heart failure. If you have a muscle problem, that's typically called a cardiomyopathy. And the most common cardiomyopathy is ischemic cardiomyopathy. Ischemic just means that the heart muscle has not gotten enough blood flow and parts of it has died or stopped contracting because it just doesn't have enough blood. That typically happens in people who had heart attacks or have multiple blockages of their arteries. That's what we call coronary artery disease. That's the most common form of heart disease in this country. When that happens and the heart muscle gets starved of blood, basically the heart muscle gets weaker and weaker and starts to dilate. It dilates because well, if I can't squeeze so much, maybe I'll get bigger. So even if I squeeze a little, more blood will get out. And so the heart gets dilated. And that's what you hear with the term dilated cardiomyopathy, where the heart gets more and more dilated, larger and larger, just to be able to push out a little bit of blood because it can't squeeze as much. So ischemic cardiomyopathy is the most common form of cardiomyopathy. Then we have dilated cardiomyopathy without ischemia. So those are things like people who unfortunately drank too heavily. Alcohol is a very common cause of the heart getting weaker and cardiomyopathy. High blood pressure. Certainly, some people who have high blood pressure for a long time, the heart can burn out and get dilated, and another cause of heart failure. Those are probably the three most common causes of cardiomyopathy in a dilated form. I'm going to talk a little bit more about the hypertrophic cardiomyopathy after in a little bit after I turn it over to Dr. Kalra, but that's another type of muscular problem. And then the main valve problems are you can either have a very leaky valve or you can have a very tight valve. So if you think about it, the valves are just the doors. There's a door getting into the muscle, getting into the ventricle, that's called the mitral valve. And there's a door leaving the heart called the aortic valve. So blood has to get in from the mitral valve, plop into the heart, and the heart squeezes, and all the blood has to get out the aortic valve. What we're going to talk about in the next half an hour or so is that some of this blood may have trouble getting out. And that is the aortic valve. So if that valve gets tighter, the blood can't get out. And there's a process called aortic stenosis where that valve gets tighter, smaller. And essentially, the heart is sort of bottled up all the blood, and that has to be relieved. So if a valve is leaky, then even though the heart squeezes and some blood gets out, a lot of the blood may fall back into the heart. So that's aortic regurgitation. Regurgitation means leaky. And if the mitral valve is regurgitant, then when the heart squeezes, blood can go back to the lungs. So it's basically, think of it like a short circuit in the heart where it thinks it's squeezing well, but if the doors are leaky, then a lot of it goes backwards and it doesn't get to your body. And if the doors are tight, then even though it squeezes hard, it can't get as much blood out, and certainly can't get as much blood out when you try to exert yourself. And that's called the stenosis. So that's a basic primer on heart failure. And ultimately, lots of things can cause it, but it is a major problem. And a lot of the technologies that we've been developing in the past 5 to 10 years have revolved around either replacing valves so that they're not tight, or fixing valves so they're not leaky. There's lots of other technologies we have, but if you have these two procedures, these types of procedures, they can make the heart much more efficient. And then on top of that, there are different procedures for the muscle problems as well. So what I'm going to do now is have Dr. Kalra comment a little bit about TAVR. What is aortic stenosis? A little more detail, and where this TAVR field came from. We all know about TAVR because it's sort of a big deal right now. And it's an important technological advance. Dr. Kalra is an expert in TAVR, and he does the procedure himself. So he'll be able to take us through the field of how we developed this, going from what patients we started with to what patients we're doing now, and culminating, and then he can hand it off to me when we talk about hypertrophic cardiomyopathy. Dr. Kalra?
Thanks, Dr. Naidu. So transcatheter aortic valve replacement, the abbreviated form is TAVR. As we all know, has been very popularized with several New York Times articles that came out after the procedure was approved for at low risk for adverse outcomes following surgical aortic valve replacement. But I'm going to go into a little bit into the background of how the technology came to where it is today. So aortic stenosis, like Dr. Naidu said, is a heart valve problem. Now, valves are doors, and the aortic valve happens to be the final conduit between the left lower chamber of the heart and the big blood vessel called aorta, for the blood to flow from the heart to the rest of the body. Aorta basically is a big blood vessel that gives off a lot of branches which supply blood to the brain, to the limbs, also to the stomach, to the intestines, to the lower extremities. So aorta is the big highway, which is responsible for blood flow to pretty much all the organs. And the final conduit that is between the heart and the aorta is the aortic valve. Now, as one ages, the valve, starts to degenerate. Degeneration occurs because the valve could get fibrosed, could get calcified, and that's just the process of aging. And so, as cardiologists, seeing patients in clinic, both Dr. Naidu and I see one of the most common valve conditions that we see is, thickening and calcification of the aortic valve or aortic valve stenosis. Now, historically, aortic valve stenosis, once it becomes symptomatic, meaning once you start developing symptoms. Now, some of the common symptoms of aortic valve disease include, symptoms of heart failure. But even before that, just having chest pain on exertion, what we call as angina, is a cardinal symptom. Then, passing out or syncope is another very common symptom, which can manifest. Aortic stenosis can manifest as several syncopal events or several episodes of passing out. And like Dr. Naidu very eloquently described, symptoms of heart failure, which would be just short of breath, exertional intolerance, just generalized fatigue. So all those symptoms, put together in the context of aortic valve disease, are representative of symptomatic aortic stenosis. So historically, the disease has been managed surgically. It's an anatomic problem. It's a problem with the structure inside the heart. And the only way to get rid of the anatomic problem is replacing the anatomic defect. This is an analogy I use commonly with patients in clinic. It is like, like Dr. Naidu said, valves are equivalent to doors. And so doors have hinges. So when the hinges get rusty, you sort of replace the hinges after you've oiled them. So, you have to replace the valve. Now, TAVR sort of has revolutionized the field, because what we do in TAVR is, the procedure now is primarily being performed by an interventional cardiologist like Dr. Naidu or myself in close collaboration with a cardiac surgeon. The chest is not being opened. We are doing this with wires and catheters, and we are doing this with accessing blood vessels, most commonly the femoral artery, which is, is similar to, I know that the heart catheterization nowadays, a lot of it is being done using the artery in the wrist, but historically it was being done through an artery in the groin. In a similar fashion, we can't put a valve through the wrist just about yet, but the most common route of replacing a valve is we use the femoral artery in the groin. So the femoral artery is accessed, you go up and over. You try to cross the valve, which is calcified with catheters and wires. And then on top of the valve that you were born with, which is now calcified and stenosed, so it's not opening as well as it should, you put a new valve on top of the old valve. So you sort of sequester the leaflets, which are calcified, and appose them against the aortic wall, and you put a new valve on top of the old valve. And that's how you replace it. And then you come out with all the equipment, and all you're left with is a little suture in the femoral artery through which you access the vessel and went all the way up to the heart. And in most cases, in the vast majority of cases that we're doing, patients are getting discharged the next day. So that's pretty much what that's the overarching procedure and what it entails. It is not open heart surgery. It is done pretty much like how a heart catheterization is done. At the Cleveland Clinic, we're doing these cases in a hybrid operating room, so that if there is a catastrophe, we have a surgeon in the room who's part of the procedure, who can take care of the patient on the table. But I know there are many other institutions, worldwide, even in the US, who are pretty much doing this procedure in the cath lab. So I'll stop there and give it back to Dr. Naidu.
Okay, great, nice description. So TAVR has become very, very popular for obvious reasons, because especially as these patients are typically in their 70s, 80s, and sometimes in their young 90s, open heart surgery is not a great proposition. They may have other problems, and you certainly don't want to have the risk of stroke, and you don't want to have the problems with it affecting the kidney and whatnot. So this is revolutionized, because also when you replace the valve, patients feel enormously better. Even at those ages, they may get a lot more quality of life, and they may have much more stamina and ability to do more. without needing to take a setback with open heart surgery. So TAVR has become more and more popular, and it's led to this one problem that we addressed in this paper. So let me talk a little bit about hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, or abbreviated HCM, is typically a genetic disorder. But when people think about genetic disorders, they think, oh, I must not have that because I'm an older person, and that would have been a problem when I was 4 or 5, 6 or 7. But lots of disorders that we have as we age are in many respects largely contributed by genetics, including things like diabetes oftentimes. And so hypertrophic cardiomyopathy can oftentimes go unrecognized for many years. Sometimes people don't know they have it or diagnosed until their 50s, 60s, or even later. It is mostly diagnosed in the 30s and 40s. And it's most commonly known as a disease that causes sudden death in athletes. So if you see people who have died suddenly on the basketball field, basketball courts or soccer fields, about 40 to 50% of those individuals unfortunately had hypertrophic cardiomyopathy, which was not diagnosed. So that tells you already that you can have hypertrophic cardiomyopathy, which is a major heart disease, and not necessarily have heart failure. You can feel good and you can be very active and you can have play sports at even a very professional level. The problem is, as they get older, they do develop heart failure. And that's because hypertrophic cardiomyopathy is a problem where the muscle is getting too thick. So the muscle shouldn't be more than about 1 centimeter thick, but once it gets over 1.5 centimeters, so that's 50% thicker than normal, that's considered hypertrophic cardiomyopathy. That is unlikely to happen with hypertension or any other diseases that cause some slight thickening of the heart muscle, but 50% or more is a substantial amount of thickening that even the most highly trained athletes who have exercised all their life never reach that level of thickness. When the heart gets thick, it's too stiff. So think of it like if you're in a room and the walls are closing in on you. So as opposed to a dilated cardiomyopathy where the walls are stretching out, you have a hypertrophic cardiomyopathy where the walls are coming in. So less blood coming into the heart means that even if the heart squeezes normally, less blood is going to go out. So that's another form of heart failure where less blood goes out of the heart, mainly because it couldn't fill completely. As people get older with that, they get more and more heart failure. And it's a slow process where they gradually feel more fatigued, more tired. They can get congestion. They can get the swelling we call edema. And it can be a major problem with heart failure as people get older. In addition, about 2/3 of them have a problem that is very similar to aortic stenosis. So aortic stenosis is a problem where the blood gets trapped on the way out. But right below where the valve is, the muscle right below that can also be thick. And it's a very common place where the hypertrophic cardiomyopathy is thick. And because all the blood has to rush out of the valve, it's very narrow there. And if the muscle is thicker there, it acts like a traffic jam even before the valve. So you get into a situation where some people with hypertrophic cardiomyopathy have an obstruction because of the thickened muscle that's acting almost like a speed bump in the heart. And it looks like aortic stenosis, but it's really the muscle before the valve. Sometimes the valve is fine, opening well, but right below it, the muscle is too tight. The muscle is too thick and causing a tightness there and obstruction there. So for that problem, we've developed two potential procedures to fix. One is something called surgical myectomy, which is an open heart surgery procedure, where they go in and they shave that muscle down so there's more room for blood. And the other is a procedure called alcohol septal ablation, which I do at Westchester Medical Center. We do probably the most in the country right now. And it's a procedure where we take also catheters, either from the wrist or from the leg. So this can be done from the wrist. We get to the arteries of the heart. And what we do is basically pinpoint the artery going to just that piece of muscle that's in the way. And we ablate that muscle. That muscle then shrinks down, gets out of the way. And now the valve sees all the blood and the blood can get out. So that procedure has also revolutionized how we treat hypertrophic cardiomyopathy, because similar to TAVR that avoids open heart surgery for valve problems, this procedure, alcohol ablation, avoids surgery for a muscle problem. Now, what's interesting is that some people, as they get older, may get both hypertrophic cardiomyopathy and aortic stenosis, because you may have hypertrophic cardiomyopathy all your life, and you were managed with medications or you didn't know about it. And then as you gotten older, you develop the aortic stenosis. And now we have both of these things and it becomes very confusing. So with that, I'm going to hand it back off to Dr. Kalra and ask him to talk about this study that we came out with. This was a big study in a major publication that got some press in Cardiovascular Business magazine. So it is, we believe, revolutionizing the field and how we tackle both of these diseases. But Dr. Kalra, take us through what our premise was, what we found, and what we're suggesting as how to treat these patients.
Sure. So no, thanks again. And we're getting a couple questions which I've looked at the Q&A screen. So thank you for the questions. Those are very relevant. We're going to get to all the questions that are being put forth. It's a privilege of ours to be in direct contact with the patients and be able to help in every or any way that we can. But coming back to the study that both Dr. Naidu and I did, which was essentially a representative study from the National Inpatient Sample, is one of the largest databases of all patients hospitalized in the US. It captures a large percentage of those patients. The question was a relevant one, and that was, what are the outcomes of patients who have hypertrophic cardiomyopathy, who then happen to have aortic stenosis? So now you're dealing with two distinct disease conditions which have a significant overlap and interplay in how they manifest. So how they manifest in patients. Both can have very, very similar symptoms. Both can have findings on heart imaging, which really require a certain degree of nuance and expertise is required in teasing the two apart. Actually, historically, hypertrophic cardiomyopathy was referred to as IHSS, which is idiopathic hypertrophic subaortic stenosis, because the findings on the echocardiogram were very similar to what the findings may be on the echocardiogram of a patient with aortic valve disease. So the reason I'm stressing on that, and I apologize for the medical jargon, but what I really wanted to impress upon is how closely related the two processes are from a symptom standpoint and from a physiology standpoint. And so the interplay becomes very interesting, and you need to go to experts who have the nuanced knowledge of cardiac imaging and treatment modalities to treat both the disease conditions. So the paper was looking at patients who, like I said, had hypertrophic cardiomyopathy and now have aortic valve stenosis and had transcatheter aortic valve replacement, what the outcomes were. And the outcomes were, if you compare it to the group of patients who just had the transcatheter aortic valve replacement, and you sort of compare it looking at data which were published in patients who've only had aortic valve stenosis and have had transcatheter aortic valve replacement, and the outcomes have been phenomenal. In the subset of patients with hypertrophic cardiomyopathy, the outcomes were not as good as they would be in patients who would just have aortic valve disease and aortic stenosis. And we then we think, so the reason why this is very important is because we think that in patients who have hypertrophic cardiomyopathy would then go on to have aortic valve stenosis, the procedure that Dr. Naidu mentioned, which is alcohol septal ablation, and he's a world expert in the procedure. He does a great workshop, teaching people like myself how to do this, safely, precisely, with great outcomes. And that is, it's very important for the pathophysiology of the hypertrophic cardiomyopathy to be addressed first before you address the valve problem. And that's very important for patients to know. So, and HCM, hypertrophic cardiomyopathy, manifests in several phenotypes. Now, phenotype is how structurally is your heart different compared with someone with a normal heart, or someone who has a different kind of hypertrophic cardiomyopathy. But what we're talking about is a subset of patients who have hypertrophic cardiomyopathy who happen to have a thick heart muscle just underneath the aortic valve. So if that portion of the heart muscle is very thick, which is just underneath the aortic valve, and now you have the valve, which is another problem, which is that the valve has become stenosed. The paper, the overarching message of the paper was that it is very important for you to address the muscle problem first before you address the valve problem. Because you could then, if you don't do that, you could land yourself, as physicians or as patients, there could be a situation where, yes, you replace the valve, but the patient is not doing well. Or, conversely, is actually doing worse than what you anticipated the patient to do, just because the muscle is now the key player in the pathophysiologic process, because it is obstructing the blood flow. So yes, you had two issues, the muscle and the valve obstructing blood flow. You've addressed the valve, but then the muscle is now obstructing blood flow. So the common denominator of blood not reaching the aorta still exists. You've just changed the mechanism of it not reaching the aorta, if I'm making any sense. And I'm happy to take any questions. I know this is complex even for cardiologists to understand, let alone patients, but I'm trying to be as generic as I can. But really the process is what we call as left ventricular outflow obstruction, meaning the muscle now becomes the key player and obstructs the outflow of blood. And, so you sort of manifest in what we call a suicide ventricle. And, there's just drop in blood pressure and patients don't do well. So, that was the message of the paper. And I'm going to head it back to Dr. Naidu to sort of extrapolate more on what I just said.
Yeah, so excellent. I think the challenge is that, the questions for the patient to ask, let's say you go in and your cardiologist, your internist finds on an echo that you have a tight valve. They may say aortic stenosis, or they may say one of your valves getting tight. They then send you to a cardiologist. And if they use the words that you might need TAVR, I guess what I want to convey is I want our patients and mended hearts to be a little more informed and say to the doctor, okay, do I just have the valve problem? Is there anything else wrong with my heart? Okay. So what are the more common things that might be wrong that are important to discuss? Is my heart muscle okay? Am I squeezing well? Are there any leaky valves too? Can this be done with TAVR, or do I need open heart surgery? And I think the point of our article is there any other, are you sure that it's aortic stenosis, or is there anything else like hypertrophic cardiomyopathy that might be causing it? And what Dr. Kalra is conveying here is that it's important to know whether you have just the aortic stenosis, just the hypertrophic cardiomyopathy, or both. Let's take them in turn. If you just have the aortic stenosis and there's no heart muscle problem below, then you probably just need the TAVR. And if they recommend the TAVR, that makes sense. Okay. If you have the hypertrophic cardiomyopathy below it, then the next question actually is it all hypertrophic cardiomyopathy? And the reason I mention that is because even for cardiologists, they are not used to seeing hypertrophic cardiomyopathy. It was considered a relatively rare disease, and most of the patients go to ultra specialists, people who are cardiologists but deal mainly with hypertrophic cardiomyopathy. So your cardiologist may actually not recognize that there's also a hypertrophic cardiomyopathy. And that's because when you have both of those problems, and you can consider them as both traffic jams in the heart, one in front of the other, two exits right back to back. The muscle problem, one exit, the next exit, the aortic stenosis. If you're in a car 10 exits back, you can't tell which of those is the real problem. And because of the fact that most people have aortic stenosis and the valve is calcified, people are going to assume that that's the main traffic jam in the heart. And if you repair that, everything gets better. But what Dr. Kalra mentioned is that if you do it in a certain order, if you do the valve first, and then you find out there's a muscle problem, the muscle problem becomes worse than it would have been even before. And that's because as soon as the valve is released, the muscle starts squeezing even harder and blood can't get out at all. Okay, and that's what the suicide ventricle is. And so you may replace the valve and be sicker right on the table. And then there's a whatever you want to call it, there's a moment there where everybody's really concerned and you can be very sick. On the flip side, if you fix the first traffic jam first by doing the alcohol ablation, then you can wait a month or two and then fix the valve and everything goes swimmingly. So that question really from a patient standpoint is, doc, are you sure that's all it is? Is there any muscle problem? Am I thick anywhere else in the heart that's unusual? And you know what? They may say, yes or no, but the truth is you'll make them pause and think about it. And I think that was the point of our article. And I don't want to scare people, but the problem, what the article showed is that whereas the overall death rate from TAVR is probably less than 2%, the death rate from having both hypertrophic cardiomyopathy and TAVR was almost 20%. 20%, I don't think anybody would sign the dotted line, right, for a procedure. So that rate is so high that it's important for cardiologists, interventional cardiologists, and patients to be informed. And that was the point of this webinar. So that's kind of what we want to convey. And I think now we can just have an overall discussion about heart failure in general. We can take some questions. So please do send some questions in. You're an attendee. And also, Andrea, if I know we've talked a lot about things. So if you have any questions on behalf of your audience and patient population, feel free to throw some our way as well. So one question is, can we get access to the paper that we're talking about? Absolutely. So we'll send that to Andrea, and she can certainly send that to all the members. But you can also very easily on the internet, I think it's an open access paper, if I remember. So it's something that you can download for free on the internet. If you put in on Google search Naidu, my last name, and his last name, Kalra, you'll probably get very quickly the article. And then it basically will have hypertrophic cardiomyopathy and TAVR in the title, and you can download it. We'll also make it available to mended hearts for that reason. Another question here was somebody who's had an aortic dissection and has an ejection fraction of 20%. So let's talk a little bit about ejection fraction. So we talked about the squeezing function of the heart that's called systolic function, the ability of the heart to squeeze in systole, which is the contraction phase of the heart. Normally a heart should eject about 55% to 75% of the blood that comes in. So that's the ejection fraction, the percent of blood you eject. If you're less than 50%, that's a reduced ejection fraction, and that's called heart failure with reduced ejection fraction. And so 20% is considered severely reduced. His question, was that his ejection fraction is 20%, and he was told he can't get a heart transplant, and his blood pressure has been low. He's on dialysis as well. So as I mentioned before, when your heart function gets worse, unfortunately, the kidney function oftentimes gets worse. You may end up on dialysis. He also had an aortic dissection, which is a tear in the aorta that Dr. Kalra talked about. It's possible, I don't know this person, but it's possible the dissection caused the kidney problem or the dissection caused the heart problem. Whatever it was at this point, I'm sure the aorta was repaired, but now the heart function is weak and the kidney function is now on dialysis. So he has a machine cleaning his blood 3 times a week, or there's other forms of it. That's typically the common one. When your heart function is reduced like that, most people actually do okay for many years. He seems to be feeling fine. So we put people on medications. Typically they're on what's called beta blockers. You might have heard of metoprolol, atenolol, Coreg, which is carvedilol, the most common 3 probably. And then you're also oftentimes on other medications like the prils, captopril, lisinopril, or Diavan, losartan. These are medications people are on. These medications unload the heart. They lower your blood pressure, lower your heart rate, and the heart can survive for a lot longer, even though it's not squeezing as well. If that gets worse and you continue to get short of breath, then yes, some people require heart transplantation. Up to age 70 or so, you qualify for a heart transplant, and the sicker you are, the more likely you are to get one. And we call those patients listed on the transplant list. So if he's doing well with 20%, I have lots of patients who have an ejection fraction of 20% and they feel great. They can swear they have no symptoms. Now, that's a combination of sometimes they're very fit, so they don't have symptoms. Sometimes they don't do a whole lot, so they don't have much symptoms because they don't push themselves that much. And so in either case, if they're able to do everything, we don't need to get in the way of that. They're doing fine. So they may live for many, many years, 5, 6, 7, 10, 15, 20, who knows, doing well. But in the back pocket, we have lots of tools to help them. So if the ejection fraction is low, sometimes people get what's called a cardiac resynchronization therapy, or a type of pacemaker that can help the heart squeeze better in a coordinated fashion that can increase the ejection fraction. We have defibrillators that help reduce the risk of arrhythmias. And then we do all these things and see how you do over years. We may do stress tests from time to time. And if you start flunking those tests and get worse and worse, then we start considering heart transplantation. So I hope that answered that question. Any other comments about that, Ankur?
No, I mean, I was just, we're getting quite interesting questions. So I'm gonna, read a couple of them to you and then answer a couple myself. But the one question that I want you to answer, because you're the expert, is, how someone has asked, how would you differentiate, or do you think senile basal septal hypertrophy, so We see that very commonly in patients who are elderly, who have aortic stenosis, but they just have senile basal septal hypertrophy that is causing LVOT obstruction. And you and I have talked about this. Is that the same disease process, or is it entirely different, or part of a spectrum with genetic hypertrophic cardiomyopathy that we see in patients? And
Okay.
the same screening guidelines for relatives that we use for HCM when LVOT obstruction is discovered in the elderly?
Sure. So to answer your question, there are some people who, as they get older, the only form of hypertrophic cardiomyopathy they have is just a slight thickening of that one spot. The way we determine whether we call it hypertrophic cardiomyopathy or what's called benign hypertrophy, oftentimes it has to do with how thick it is. So if it's more than 1.5 centimeters in that spot, typically it's not just benign hypertrophy of the elderly. I think we called it that for many years because we didn't have genetic testing and we didn't realize that it's actually a problem. There's lots of things that we didn't know for many years, and now we realize it's causing a problem. So I guess the point I want to make is whether or not it's hypertrophic cardiomyopathy, if the muscle is thick enough to cause obstruction, to cause a traffic jam there, then it doesn't matter what you call it. It is a problem, and the problem has to be addressed. Where it becomes relevant in terms of really knowing whether it's hypertrophic cardiomyopathy is in the genetic aspect. So, because if it is truly genetic hypertrophic cardiomyopathy, then even though we fix you and you feel well, we need to make sure that the rest of your family is protected. So I see about 1,000 or more hypertrophic cardiomyopathy patients in my practice now. And after I work on each patient to make sure they're breathing well, not passing out, feeling well, I then concentrate my attention to make sure they don't have any risk of arrhythmias and they're not going to have any sudden cardiac arrest. And so we make a determination of whether they would benefit from a defibrillator or not. And we do that screening from years to years to make sure that my patients are safe. The third thing, though, is to do genetic testing and screening of relatives to make sure we're catching everybody who might have the disease. I already mentioned that many people may have this and not know it. So it's very important that the patient brings in their family or informs their family, and that means any blood relatives, their brothers and sisters, their parents, and their kids and their kids' kids. Because the disorder travels very frequently in families. Half of all family members will have the gene that you're carrying. Many of them may not have the disorder. They may not have that phenotype that Dr. Kalra is talking about, but they may develop it later, or they may have it and not know it. The most important is to screen your kids who are between the ages of 12 and probably 25, because that's when they're also doing most of the sports. And the last thing you want is that I'm taking care of you for your hypertrophic cardiomyopathy or your TAVR, and then that goes well. And then 2 weeks later, you tell me that your niece or nephew or your grandson or granddaughter had a sudden arrest or God forbid died. And it's nobody's fault rather than the fact that we need to concentrate on the whole family. This is trouble in this society because most people tend to feel like, I have my problem, this is my heart problem, and my problem is not your problem. But in this disease, when you're talking about these kinds of disorders, it is everybody's problem. And it's important to tell everybody in the family that they shouldn't ignore it and they shouldn't assume that if they feel well, that they don't have something. That's just what we call denial. And it's better to know and to feel that you're safe. And so it's not a death sentence. If we find you have hypertrophic cardiomyopathy, almost everybody lives to their 80s. They live a normal life if we know about it and can treat it, either with ablation or surgery, defibrillators, genetic counseling, whatever it is. It's more important to know and have peace of mind, and then you can go on with your life. Hope that answered that question.
Yes, no, that was a great answer. I'm actually answering a few questions by typing the answers as we speak, but I'm also making sure that we answer them in an open forum for others to appreciate.
Yeah. Why don't you throw some on? Because I think probably when we do this and record it and broadcast it later, we won't be able to see the answer, so we should.
Absolutely. Sorry, Andrea, I didn't mean to interrupt.
Oh no, it's fine. I was actually going to say the same thing. Yeah, when it's I don't think that when the playback is happening, which we're hoping other people watch, they'll be able to have the luxury of reading the comments. So if there's a question that's really important, we maybe should verbalize it. I actually had a question, and I was just wondering if you could answer. So you're talking about TAVR and hypertrophic cardiomyopathy and making sure that that's taken care of before the TAVR. What if they're doing a an aortic valve replacement via surgical replacement, does the hypertrophic cardiomyopathy seem to have the same type of problem, or is it just the TAVR?
That's a great question. No, it's exactly the same. And so we should stress that there are some people who don't qualify for TAVR, and I'll have Dr. Kalra comment on that in a second, because that's important too. And in those patients, you still have to look for the hypertrophic cardiomyopathy in the muscle. And when they do the surgery, they'll actually do the shaving, they'll do the myectomy. So they'll take the valve out, they'll shave the muscle down, and they'll put the new valve in. Now, importantly, just like alcohol ablation is probably only done in high quality in about 20 places in the country, surgical myectomy is also probably only done in about 20, 30 places in the country like that. So if you find out that you have both, you need to ask how many alcohol ablations have they done at your institution that you're at, or how many surgical myectomies, that's M-Y-E-C-T-O-M-Y, myectomy have they done? Because they've all done lots of valve replacements, either surgical or TAVR, but most places have not done a high volume of the other one, of either the myectomy or the alcohol ablation. In those situations, either you need to tell them that you'd like somebody to come in to help for those, or that you want to be referred to a place that does both together. Now, that sounds a little selfish because we do that and Dr. Culver's place to do these things, but it's not. I'll tell you that patients need to have the best, no question. And I will, he already alluded to the fact that I run a training course for this, so I'm committed to making sure that more people learn this and can do it, because as TAVR gets more common and hypertrophic cardiomyopathy is more recognized, it's going to happen all over the country. And certainly I can't travel all over the country and do this, and people who know how to do it can't do it. So to get the quality up, we have to create more centers of excellence for both TAVR and for alcohol ablation and surgical myectomy. So we're committed to doing that, but that's going to take some time. In the meantime, an empowered patient and an educated patient will be able to talk to us, talk to Andrea. We'll feed her the different sites that do all these things. And the interesting part is, for the TAVR standpoint, if you need the alcohol ablation ahead of time, you can go somewhere for the alcohol ablation and then get the TAVR done a couple months later. One thing I didn't talk about is that doing the alcohol ablation first buys you some time. And that's because some people's aortic stenosis is not as bad as you think, because the traffic jam may have been the hypertrophic cardiomyopathy first. And once you get rid of that, getting rid of one of the exit problems, the other one actually gets better. So at least for the short term, and then you can delay that for a few months. So I have a lot of patients that come to me from other hospitals, even from Connecticut, New Jersey, Pennsylvania, that come to Westchester for the alcohol ablation. Then when I'm done, I send them back, and about 2 or 3 months later, we repeat the ultrasound, which is called the echocardiogram. Muscle problems now shrink down, and we take a better look at the valve. And if the valve is still tight, then they can go for TAVR. Now, TAVR is being done at most hospitals, most large hospitals, so that can go back to their hospital and get done. So I think what we're emphasizing here is a relationship between all TAVR centers and places that do the ablation, because we can funnel those patients to and from us back to their center and get the TAVR, and over those 3 months it can all be done. The same thing cannot happen with surgery, since it has to be done at the same exact sitting. During the operation, you need to go to a place that'll do the myectomy and the surgical repair at the same time. So does that answer your question, Andrea?
Yeah, that was great. Thank you.
Dr. Naidu, just a follow-up, a couple questions, which I think are excellent questions. One is, what do you do about mid-cavity obstruction? Is the approach the same, which I think is an excellent question.
Yeah. So mid-cavity obstruction, typically that has to be addressed by surgery. So there are some places that do alcohol ablation for that, but I'm not a proponent of that, and I wouldn't advise it. And the reason is that the mid-cavity obstructions usually is a lot of muscle in the way, and you have to do a lot of ablation. And I'm not convinced that doing that much ablation won't have long-term consequences for the heart. So I refer all the mid-cavity obstructions. What we're talking about is not that it's narrowed below the valve, but further in the ventricle, in the chamber itself. It's so thick and taking up so much room that the muscle is touching itself, and some of the blood gets stuck at the tip of the heart called the apex. What we do for that is a type of myectomy called an apical myectomy. So that's a surgical procedure that's even rarer than the typical myectomy, done really at probably only 5 or 6 places in the country right now, where they open up the heart from the tip of the heart and from the aorta and then in between, they basically shave out the muscle in the middle. It sounds a lot, but our patients do quite well. And you basically allow more blood to flow inside, more room inside the heart. You make the room bigger by taking out more of that muscle. And remember, these patients have too much muscle, so it's not harmful to the heart. It actually makes the heart behave better. So mid-ventricular obstruction, we recommend a combined apical and subaortic, below the aortic valve, myectomy. And we do that at Westchester Medical Center. Mayo Clinic was probably the leader in this and still does probably the most in the country. I think Tufts Medical Center does it, NYU does it, Stanford. These are off the top of my head, probably the biggest places that are able and capable of doing this type of myectomy.
And then, the other question is a follow-up question, which I also thought was an excellent question, was, are you looking at a particular LVOT gradient cutoff before you're considering alcohol septal ablation before transcatheter aortic valve replacement? To which I responded like, look, the gradient is load dependent, so it's going to change frequently. But if there is significant gradient at rest, is something you should consider.
Yeah. So I think we have to separate into two categories. If you just have hypertrophic cardiomyopathy, no valve problem. And if you have the hypertrophic cardiomyopathy and need the TAVR. So the first one is if you just have hypertrophic cardiomyopathy, we have a cutoff where what's called the pressure gradient, when the heart squeezes and the blood gets trapped at the muscle level, the pressure builds inside the heart before it busts out. And as it builds inside, it's higher than in the aorta when the blood leaves. So that difference is called the gradient. It's a simple subtraction. Let's say your pressure in the ventricle goes up to 100 just to get 50 out. Well, that's a gradient of 50. That number 50 is what our cutoff has been. So if the heart has to generate 50 millimeters of mercury more than is ultimately able to escape the heart, that is too much pressure in the heart and is a major cause of obstruction and a major cause of heart failure. So that's our cutoff. And so we'll oftentimes do echocardiograms. We'll make you take a deep breath in and hold your breath. We may stimulate the heart to see if you hit that cutoff. And if you hit that cutoff, we increase the medications you take, but ultimately, if you can't tolerate the medications or continue to have symptoms despite the medications, then we proceed to the alcohol septal ablation or the surgical myectomy. We make the distinction between the two based on where the thickness is. And I already told you that if the thickness is much lower or much more severe, they go for surgery. If it's more focal, meaning right underneath the valve, they typically go to the alcohol ablation. Older people typically get alcohol ablation because surgery is more risky in that population, and younger people typically get the myectomy. Now, that cutoff is less in a patient prior to TAVR, and that's because when you have a tight valve, it actually tethers open the muscle area a little bit. So if you have any obstruction there, even 10 or 20, my procedure is to do the ablation in those patients, because once that's a sign that after you replace the valve, that may go to 50, 60, or 70, which is that suicide ventricle that Dr. Kalra mentioned. So I have recommended, and we had another paper that came out about 3 years ago about that topic, that if there's any obstruction, not the 50, but obviously certainly if it's 50 or more, but if it's even 10 or 20, those patients should have the alcohol ablation before the TAVR, because it's better safe than sorry. Because after you do the TAVR, if it gets worse, it's very hard to treat, and patients can get very sick. So that will be my information and my advice for that situation.
I'm going to answer a couple of questions which were asked, in relation to TAVR. One question was someone who's had an AV nodal ablation. I don't know what the indication was, but the most likely indication is atrial fibrillation. Then there's a pacemaker put in. Can you still have a TAVR? And the answer is yes. It's a valid question because when you put the valve, it sits in close proximity to the electrical conduction system of the heart, and can have effects on the electrical conduction system of the heart. It can damage it, causing you to require permanent pacemaker. In fact, when you look at the national data, the permanent pacemaker rates, they're dependent on what valve you use, but are anywhere between 3 to 7% for a balloon expandable valve versus 10-12% for a self-expanding valve. And so a lot depends on the technique with which you deploy the valve. But if you've had a pacemaker already, it's one less thing to worry about, honestly. And so, you really should then, if you require, are eligible for a TAVR valve. And the other question that someone asked was using cerebral embolic protection. which is, you're using baskets to prevent strokes while replacing the valve. And do we use them? At the Cleveland Clinic, systematically, we use them in every case. I'll be very honest, nationally, that's not the case because the question is still wide open. The reason why this is even a question is, studies have been done in which they've looked at magnetic resonance imaging or MRI scans, the brain MRI scans in patients who've had these valves replaced with wires and catheters, so with TAVR, and they've shown that in 88% of the patients, you do find something on the MRI. Does that translate into clinical stroke or clinical stroke equivalent? And the answer is no. It does not translate into anything clinically. So, the proponents of the technology have said, look, and in the only trial which was done, there was no difference in stroke in either the control group, meaning patients who didn't get the device, and the treatment group in which the patients got the device, but the device itself got debris in 99% of the cases. So what does that mean? So the proponents of the technology say, look, we need to do it systematically in every patient. I think the non-believers of the technology say that it does not need to be done. Now, the trial was done, it was not looking at patients who got it versus patients who didn't, it just looked at the device. There wasn't particularly any difference in stroke. So I think the field right now is equivocal, and a randomized study is being planned by the manufacturer of the device to see where this is headed.
You're getting paged. So I think we're coming on the hour. I don't want to keep people longer than that, but I'm hoping people enjoyed this frank discussion. I think more needs to be done with doctors talking directly to patients, especially nowadays when we have social media and enduring content, meaning that we can keep this on the web and it can live on past us. This hopefully gives you a little glimpse into how we treat hypertrophic cardiomyopathy, how we treat aortic stenosis, what to look out for with the two things together, and what questions to ask. So I do want to thank Mended Hearts, Dr. Kalra, Andrea, Jody, who's behind the scenes there, for putting this together. We will box this up and put this on the web. Andrea, you want to have any last minute comments?
Yeah, no, I would just like to thank you guys both so much for being a part of this great discussion. I learned a lot, and I hope everyone listening did as well. If anybody has questions that they would like answered, they can email me at Andrea, ANDREA.Baer, BAER, at mendedhearts.org. And I will do my best to get the questions answered for you or point you in the right direction. We will have a PDF of your paper or a link to the paper, whichever one we can figure out. And we will share that with everybody. And I just wanted to thank you again for taking the time out of your Saturday to join us. So thank you.
Thank you. It's our pleasure.
Everyone have a great day.